It's my honor and my pleasure to be able to introduce the next speaker. Somebody that I've known from my years at UCLA. My patients, and are no longer at UCLA, but my patients continue to ask me about her because she just was such a great bedside manner, especially for a surgeon. I'm just kidding. It's like, no, but Dr. Nina Shapiro, who's a head and neck surgeon, who, again, like I said, was phenomenal, was always really my go-to during her years at UCLA. And still, now I know that I can refer patients to, I will be my go-to then. But also an author, which it was very impressive. She has published many books, but the one I'm going to tell you about is called Take a Deep Breath, Clear the Air of Health for Your Child. And they're all available on Amazon. So if you need Christmas presents or stocking stuffers, this is a good go-to. But she's going to be speaking today about the impact of wildfires on the pediatric upper airway. So Dr. Shapiro.
Well, good afternoon, and thank you again so much for inviting me to speak today. So we're going to have a little bit of, for some of you, an anatomy lesson, for some of you, an anatomy review, and I apologize. But I think it's really important because when we think about all of the dangers of wildfire, smoke, and exposure, I'm not going to be talking about acute airway burns, because obviously, unfortunately, we've seen a fair amount of those just from house fires, of inhalation injuries. But these are really the long-term impacts that we're all seeing, not just in Los Angeles, but really all across the country and outside of the country as well. And, we think about breathing issues, we think about lungs. It's all the lungs, but it's got to get to the lungs somewhere. So I'm going to talk about sort of all the things in between the air that we're breathing and the lungs. We talk about, we're ENT doctors, we're dura de pleura. So we do try to stay out of the lungs as often as possible, but we're just going to go through a little bit of what the upper airway is sort of impacted by these horrible fires that we're dealing with. Okay, so just again, a review. We're going to go through all of these. The pediatric upper airway. So we have the ears, and we often don't think about the ears as part of the airway, but the ears are part of the upper airway. Not this part of the ear, but the middle ear is part of the airway. When a child has an ear infection, it is an extension of a respiratory infection. So the ears are often overlooked when we're thinking about the airway, but it's important to consider, especially in kids. And of course, the eustachian tubes are really how the impact is getting to the middle ears. The nose, the sinuses, the oral cavity, the hypopharynx and larynx, so the voice box, vocal cords, and the trachea. We're allowed to go in the trachea as ENT doctors, but we try to stop after that. So again, here's our little anatomy review. This part of the ear, the external ear, the auricle, the external auditory canal, really have nothing to do with any sort of wildfire exposure or any sort of airway issue. It's really all here, the middle ear. So you can see here's the eardrum. It's a piece of skin. And then medial to that is mucosa-lined middle ear. And this little tube here is the sort of end point of the eustachian tube that goes to the middle ear. So that's what we talk about when we're talking about any sort of airway injury or airway exposure to the ears for the kids. The nose, it's not just the little tip of the nose. It's not just to look cute, as most of you know. There's a lot to the nasal airway here, and just sort of a reflection of back in the COVID testing days. You don't want to go up, you want to go back. Breathing up into the nose goes to the skull base. You want to go back posteriorly, parallel to the roof of the mouth. The tribinates line the nose. They're often quite enlarged in children. And this child here, sorry, oops, how do we go back? I'm going to go back to this child here, you can see has really no adenoid enlargement, which sits in the nasopharynx, but the adenoids are often very enlarged in kids starting at about age 18 months or so. So those usually are obstructing the front part of the nose secondarily. So children usually have enlarged nasal tissues, turbinates, lining of the nose due to adenoid enlargement. So that's where all of the contaminants tend to get trapped in there. The sinuses, this is kind of an interesting picture. It never really looks like this when you have a sinus infection. It's not a fishbowl, but this is what a normal sinus should look like in a child or in an adult. Sinuses don't drain by gravity. You can see there's this little line right going up from the sinus right there. That's called the osteomeatal complex, and that's very, very easily obstructed, and that's how children get sinusitis. And then obviously if there's any sort of fluid that accumulates in the sinus, that's usually from that tiny, tiny little opening, which is usually about 2 millimeters into the sinus. And if their nose is congested, secondarily, their sinuses will be involved. The throat, we've all had this. For those of us who live here, anywhere near here, that burning feeling we have in our throat during wildfires. And that's usually, especially in kids, that burning sensation is from nasal congestion. So you should be breathing through your nose. If you're not, if it's congested for any reason, you're going to be a mouth breather, hopefully temporarily. And that's what that burning sensation is in the back of the throat. This is the voice box, for those of you who don't see this regularly. These are beautiful vocal cords here. You can see these nice, clean vocal cords. These are called the true vocal cords. Around here, this kind of fullness, those are called what we call the false vocal cords. They're not fake, but it's just muscular tissue. The arytenoids back here, and then this little sort of smile face indentation posteriorly, that's the entry to the esophagus. So this area is also very, very susceptible, especially in young kids. This is an adult larynx, but you can see how this would be very, very irritated with any sort of exposure. Okay, so moving a little bit further down, the tracheal airway. So we talk about the laryngotracheal airway. And we have here in this photograph, in this image here, we have the hyoid bone, which is just a floating bone in the neck, the thyroid cartilage, which is what's covering the larynx and the true vocal cords, the cricoid cartilage, and then we have the tracheal rings. So for any non-medical person in the room, in a child, what is the narrowest part of this airway? Which structure? Don't say the thyroid gland, but of all those structures, which is the most critically narrow part of the child's airway? No medical people can answer. Keep guessing. What's that? No, of this airway. There's a prize for the winner. Keep guessing. Who said cricoid cartilage? Cricoid cartilage. The reason for, you can win a book. If you have any kids. Another book. The Ultimate Kids Guide to Being Super Healthy for 5 to 12-year-olds. Come on down. If you know any kids, that's for you. Enjoy. Good job. Okay, it's very important to know that in an adult, the narrowest part of the airway is our vocal cord area, our larynx, thyroid cartilage. The cricoid cartilage is the only complete circular cartilaginous ring of the airway for kids or adults. Everything else has soft tissue in the back. And so that's really important, especially for any sort of airway compromise. The tracheal rings share their posterior wall with the esophagus. The thyroid cartilage, the posterior wall is open also with the upper esophagus. The cricoid cartilage is, we call it the signet ring, for those of you who went to high school. It's a round cartilage, and that's very, very important because that's usually the most critical point when you talk about a child who has subglottic stenosis or stridor. It's the cricoid that's of concern. Okay, so wildfire smoke, I'm sure you've been already discussing the horrible contents of wildfire smoke. These are just some of them, the gases, the heavy metals. microplastics, and obviously with the horrific fires last January, because there were so many structures that were burning and cars and batteries, the sort of toxic elements in the air were even worse than a typical, what we would say is a wildfire, where it's really primarily, trees and wood and sort of natural substances. Because there was so much non-natural substances, we had a lot higher content of sort of quote unquote toxins in the air. For the airway, the most important component is not the actual gases, it's the particulate matter, the 2.5. So those are any objects that are 2.5 microns or smaller. Those are the direct impact on the upper airway, much more than any of the fumes or toxic gases that are released. So ear infections, again, we're going back to, yes, the ears are part of the upper airway. And how does this sort of work? So a child will have nasal congestion from inhaling these small particles. They can develop a respiratory infection because they're congested, and that extends to the middle ear. So we tend to see more episodes of otitis media after wildfire exposure. The eustachian tube in a child is very small, and it's very short, and it's very horizontal, as opposed to in an adult. When you're descending in a flight, you can swallow and pop your ears. The reason why the babies are crying is because their eustachian tubes are short and horizontal and not functioning. And so any sort of upper respiratory congestion is going to make them much more susceptible to ear infections. So there really isn't a lot of data out there on actual episodes of otitis from wildfires. The one interesting study I found was from British Columbia, looking at the fire season from 2017. So I was on vacation in 2017 during the fires, but I was in the next province over. We were in Banff in Alberta, and we were wondering, this is such a beautiful place, and the sky is orange, completely clueless that the reason why it was so beautiful was because in the next province over, there were these horrific fires. So there was a study during this wildfire season comparing it to a less severe wildfire season in British Columbia. They looked at pregnant subjects, about 80,000, a little under 80,000, and they compared their exposure and how it would impact their children in the first year of life if they were exposed during pregnancy. And what they found are a couple things. They looked at different times of gestation and if there was more of an impact during certain times of pregnancy. This is a little bit of a soft call, although it was a large study, and they found that there was a much higher incidence of otitis media as well as lower respiratory tract infections for women who were exposed during the 19th to 28th week, which is the most important developmental stage of the eustachian tube, as well as the bronchioles and lower respiratory tract. And though their children had the highest incidence of otitis media and lower respiratory tract infections in the first year. That was the closest I can find for any sort of, call it direct or really indirect correlation between wildfire smoke exposure and actual otitis media. And this was published just a year or so ago. Okay, again, the eustachian tube, just to remind you that this is the eustachian tube, and this sort of space that's sort of never land, this is the nasopharynx. This is not the nose, this is the back of the nose. This is where in a child the adenoids sit, and they tend to obstruct this area right here, the eustachian tube orifice, which is why this can't stay clear. This should be aerated and open, but in a child this tends to be blocked, which is why all of the fluid builds up behind the eardrum. And this is a diagram just again to demonstrate that you can see here in a child, the eustachian tube is short and horizontal. So there's a direct line from the back of the nose to the middle ear. And then in an adult, it's longer and has more of an angle to it. It doesn't go into the nose, it goes into the nasopharynx, kind of a funny picture here, but it has a much longer path and it tends to be much more open. The adenoids tend to dissipate at about age 16 to 18. So most adults don't have adenoids obstructing their eustachian tube. Okay, what about sinusitis? Similarly, because the particulate matter lodges in the nose, they get a local inflammatory response. It's very hard for kids to clear this, especially young kids. They don't blow their nose, they don't clear their nose. And so they're much more susceptible to sinus infections during these times of exposure. And just the relatively low volume of a pediatric nose puts them at much higher risk for sinus-related issues due to the particles. This is a CT scan of sinusitis, just to remember that these are the sinuses here, maxillary sinuses, ethmoid sinuses, clear, not clear. This happens to be a CT of a patient who's had surgery, and they have these little calcifications in their sinus, which is indicative of allergic fungal sinusitis. So we haven't necessarily, this is a relatively rare disorder. It's not the fungal sinusitis that we see in immunocompromised people. This is allergic fungal sinusitis. Immunocompetent allergic individuals tend to get this, but this is what a CT scan looks like with the sinuses filled, not that little fishbowl that we saw in the diagram before. And this is how the throat can look from this chronic irritation. You can see this is an airway with no tonsils, but you can see the posterior pharyngeal wall is irritated red. You see those little bumps, we call it cobblestoning in the back of the throat. And this is an adult, and you can see there's so much irritation, a little bit of mucus stranding just from having had all that exposure. And then the larynx, this is a healthy larynx here. You can see these beautiful vocal cords, clear, open. This is entry to the cricoid, which then leads to the trachea. And then this is what laryngitis looks like in a child. You can see this very inflamed vocal cords here, little posterior inflammation as well. And again, these are the kids who are breathing through their mouth. They can't breathe through their nose. They're getting direct particulate injury to the vocal cords themselves. So we're going to talk a little bit about croup. This is, for those of you that do general pediatrics or pulmonary, something you see pretty often. Certainly as an otolaryngologist, we see this quite often. It used to be considered just parainfluenza virus, February to May, 18-month-olds to 3-year-olds. That, I feel, has completely changed since COVID. Really, anything can cause croup. Any viral illness can cause croup. Doesn't tend to have a season anymore, and it also doesn't tend to be sort of fixed to those age groups. I'm seeing much more croup in older and older kids, could be multiple viruses. And again, it's the cricoid cartilage that is a very, very critical part of the pediatric airway. Any inflammation in that is why kids have such severe stridor and breathing problems. And it's the only complete cartilaginous ring. This is fun. Everyone's eyes are going to glaze over, or they're going to say, wow, I love that formula back from high school physics. So something to just remember, and this is obviously important for croup and for the cricoid, but really any airway obstruction, whether it's the nose, the sinuses, the oral cavity, child with big adenoids or big tonsils. The most important part to know about this formula is that resistance is inversely proportional to the radius to the 4th power. So meaning if you have 2 millimeters of inflammation, it's going to impact the resistance by 2 to the 4th power, not just double. So that's why these airway narrowings are so critical. Again, even if it's just in the nose, the formula still applies. If they have a millimeter of congestion, it's going to increase the resistance of airflow to the 4th power. And this is what croup looks like. Again, the vocal cords in croup are not involved, even though oftentimes these kids sound a little bit hoarse. It's right below the vocal cords. This cricoid area that becomes critically narrowed. And, the children can obstruct quite significantly. This is what croup looks like. You can see these beautiful vocal cords here, and then all of this inflammation. And if you remember that formula, so normally a child's airway should be about maybe 4 millimeters, and this looks like 2 millimeters of obstruction. So that's a pretty significant amount of increased resistance just from a millimeter or 2 of obstruction. So there is some data on this. This is most of the work, besides being in Canada, has been in Northern California. So I think we have a little bit of work to do because there really wasn't much as far as wildfire data on the airway from this part of the state, but I think that is yet to come after last year. So this was looking at ER visits at Stanford Children's over about a 10-year period. And they did find, again, with this metric of particulate matter, increased croup episodes, visits to the ER, as well as new onset dysphonia visits. And those were probably some overlap as well, but that was a significant difference that they found during increased wildfires in the Bay Area. Going to move a little bit down because we do intubate patients and we are very involved with patients undergoing general anesthesia. So we have our beautiful airway here, vocal cords, that kind of horseshoe at the top, that's the epiglottis, looks very healthy. This is on the C, that's an endotracheal tube in the airway. And then this is right before the patient's intubated. And you can see when you elevate the larynx, you can actually see the entry to the esophagus in the lower right image. And that's why, we always want to make sure that the resident doesn't intubate the esophagus. Bad form, or that we don't either. Okay, one more study about this. Also in Northern California, they looked at about 600 patients, pediatric patients undergoing elective surgery. So usually that means outpatient surgery, although not necessarily, but certainly not emergency surgery, inpatient surgery, really just elective surgery. And they looked at respiratory events, adverse respiratory events, which usually means in the recovery room, whether it's an oxygen desaturation, laryngospasm, bronchospasm, needing extra oxygen, needing inhalers or nebulizers, needing reintubation. And they looked at children with a history of reactive airway disease or asthma versus children who have no prior airway history. And they found no difference in the children who had no history of reactive airway disease, although they did find a very significant difference in the children who had a history of reactive airway disease, about 30%, 35% of adverse events, which actually that seems pretty high in and of itself. But these were probably kids who needed an extra, nebulizer or extra O2 or some support. But over half of them had an adverse event in the recovery room if they had a history of reactive airway disease, if surgery was done during a fire season. And this was also a pretty recent study in anesthesia. Okay, so a couple of things to notice about this kind of creepy picture here. Woohoo! So I used to be a regular on local Fox, and you can see that there's obviously like a fire background. If you look over here, this was October, and at 3:37 it was 94 degrees, which I think says a lot in and of itself. And I look pretty happy and blissful, kind of clueless. So this was, and younger, this was about 6 years ago, October of 2019, for those of you who were in Los Angeles that month. There were fires in what we would consider the typical fire areas, the North Valley, West Valley. And so I came on to talk about airway issues related to fires. Little did I know that 48 hours later, there would be a fire in West LA, and we were evacuated at 2:00 in the morning, the first of many subsequent evacuations, house still standing for now. And a few months after that, we were scrambling for those masks, those N95 masks, where for those of us who were working as in inpatients or in hospitals, we would get one N95 mask. I don't know if you remember this, and we would have to wear it every day and put it in a little paper bag and get it washed once a week. And that became the norm. But boy, did I live happy. So I just have a little clip. People think that, if we're away from the fires, it's okay to be outside, and the air quality, even 20, 30 miles from these fires, is terrible right now.
So what do you do?
So what do? First thing to do is stay inside if you can. If you have air conditioner, it's fine to use. If you can have it on, recirculate. If you have to go outside, especially for young kids, and if you're going to be outside for a prolonged period of time, they have these masks. And you see people around with bandanas and with small masks. Those don't work. Those don't really make a difference. You need those N95 or P100 masks that really filter out the air particles that you were breathing in. We don't realize how bad this air quality is right now. So yeah, who knew? I certainly didn't have one of those masks back then. And look, it was 91 in Ontario at the time. So, I think something to just keep in mind is that whatever we know now, we don't know what's to come. And we've sort of started to get a grasp on, the use of masks, whether it's for a viral illness or for fire safety. And we've got a grasp on evacuations, and we've got a grasp on all the toxins that we're being exposed to, but we don't know what we don't know. So I think just, general preparedness and never assuming that, sort of all the knowledge is obtained, that, a lot of this, whether it's from a fire or a pandemic, is, we learn kind of as we go. People think that, if we're away from. Okay, enough of that. So just, in general, what the wildfire smoke does, remember the upper airway, there's a lot to it. It's not just breathing it into your lungs. There are the ears, the nose, the sinuses, the mouth, the hypopharynx, the larynx, the cricoid, and the trachea, all sort of critical when we're sort of learning about how to prevent damage, especially in young kids. For the upper airway, it's the particulate matter that is the most critical, not the noxious gases as much. So, for those of you who take care of young children, extra monitoring during these critical times, for respiratory illnesses, they're much more susceptible, especially if they have baseline inflammation. And then also for the surgeons, or anybody who does procedures, we should really think twice or really be prepared for kids who are going to be undergoing elective procedures, especially if they have a history of reactive airway disease, because at least from that one study, there's over 50% chance that they're going to have a problem afterwards. And thank you. Happy to answer any questions. Any questions or moving on? Now that we know what the cricoid does. Yes.
Random question, but do you have any tendency to increase or decrease the threshold for operating during wildfires?
Oh, sure. So the question was about whether, as a surgeon, I would consider operating on a child during wildfire season or not, more inclined or less inclined. Interestingly, the biggest fire was obviously, where are we now? 11 months ago. Nobody was coming for surgery. Nobody was coming for elective surgery for various reasons. The following months, we were starting to see kids come back for elective surgery. And I didn't know about that data actually then. And, retrospectively, I don't think we had any particularly increased complications. But I think, especially if it's going to be these fires that are going to be cropping up, which we know it's bound to happen, unfortunately, and where it's not the type of situation where everyone leaves town, I would probably, hold off certainly on anything elective, certainly if it's a child with reactive airway disease.
One more question.
Yes.
Any role? Sorry.
And I apologize, these are such pulmonary questions, but any role in sinus rinses during these types of
great question. Oops, sorry, that was so loud. Yes, I think that's a great question. The question is whether to use sinus rinses for kids and adults. So there's a lot of really good data on just plain old nasal saline in any form. It doesn't have to be the kit that you buy. It could be plain old saline. It reduces the risk of respiratory illnesses. It reduces the duration of respiratory illnesses, and certainly will have a mechanical benefit of flushing out the particulate matter. So, it's a tough sell for a lot of kids. I recommend it for most of my patients, and what I usually recommend, especially for the young ones, meaning like the 18-month to 3-year-olds, like do it in the bath. they're wet anyway. They like to play, let them do it themselves and give them some time. It's great to start on infants because then they just get used to it and actually they tolerate it quite well. But that's a great point for all of us. Get your saline, bring it on the plane. Yeah. Any other?
What's your opinion on Zicam using zinc? What's your opinion on Zicam using zinc nasally? Do you really believe the studies or not?
So the first book I wrote was called Hype. So yeah, Zicam is interesting because there's a lot of benefits. It's zinc containing, and so it's found to reduce, duration of respiratory illnesses and offer some protection. The early Zicam was causing permanent anosmia. That was one of the first calls I got from like an outside, company to review Zicam because there were several cases of permanent anosmia from Zicam. So I don't know. I mean, you probably have some experience with it or, some of your patients, but I don't usually recommend it. Plus minus. How's that? All right. Well, thanks again. Enjoy.